Good afternoon, Colonel Croy, classmates. I'm Lieutenant Merriam, and this is Lieutenant Latomsky, and we're going to be talking about extracorporeal shockwave therapy for the treatment of plantar fasciitis, chronic plantar fasciitis. So as an overview, we're going to be going through the PICO question, our search methods, the theory behind extracorporeal shockwave therapy, the patient population under consideration, and then we're going to critically appraise our findings, and then wrap it up with some safety concerns, effectiveness, cost, and final recommendations. So our PICO question was, for patients with chronic plantar fasciitis, what is the effect of extracorporeal shockwave therapy on reducing foot pain or self-reported outcome measures versus a comparative treatment?
Alright, so our search strategies, we use PubMed, Google Scholar, and Cochrane collaboration, as you can see. Basic terms, obviously we use plantar fasciitis, chronic, comparative treatment, pain reduction outcomes. We've tried to limit it within the last 10 years. We tried to pick ones that were within 5 years, but we didn't want to not have the research that was done before that. We made sure to include ESWT in both of these, and then figured out what we saw. There we go. So the underlying theory behind extracorporeal shockwave therapy is basically acoustic pressure is produced through a medium. It's kind of it's different than ultrasound because it's acoustic medium as opposed to ultrasound, and that basically the possible mechanisms behind ESWT is that the physiology on the pain receptors and microtrauma. So basically it's causing microtrauma to the area to then stimulate neovascularization to that specific area. And there's two different kinds, focal and radial shockwave therapy, and used for pain relief and improving functional outcomes, and also to bring neovascularization, like I just said. So the patient population that we focused on is patients with chronic plantar fasciitis. With most of the studies that we found, it was mainly people who failed conservative treatment, but we'll get into that later. Basically, what we found was that plantar fasciitis is a degenerative alteration of the plantar fascia that affects up to 10% of the population. So we're definitely going to be seeing this in our clinic. We need to have ways to treat it. Preferred treatment is to suppress the pain, restore mechanical function of the plantar fascia, and improve gait to try to help biomechanically improve how the plantar fascia works. So we also found that ultrasound has been used for analgesic effects, along with corticosteroid injections and custom orthotics, night splints, and immobilization. Also, surgical intervention is common once a lot of these conservative treatment has failed. So that's another point we'll bring up later on, where maybe this is more compared to, ESWT might be more compared to surgery as opposed to other conventional physical therapy. So we have one meta-analysis, and then we have two RCTs that are one's comparing it to conventional physical therapy, and one's comparing it to surgery, so plantar fascial release. So the first one is this article comparing it to conventional physiotherapy. The Pedro score on this article is a 7 out of 11, and mainly because it lacked blinding, which is a concern, but it's kind of why it's a little bit lower. But the biggest thing that they found was immediately after the treatment and then 3 months post-treatment, there wasn't a big difference with conventional physical therapy versus the ESWT. That's not to say that ESWT wasn't effective. It actually was occurred more faster, the outcomes did. And but as opposed to conventional physical therapy, it didn't really have versus surgery. So this one is resistant plantar fasciopathy, shockwave versus endoscopic plantar fascial release. This one had a little bit higher of a Pedro score. It was 8 to 9. It's hard to say. There was one of the Pedro questions I was not completely sure if it was a yes or a no, because blinding in this is really hard to do when you're having surgical techniques. You can't really blind the surgeon or the patient or the physical therapist to someone having surgery. So there was 34 patients in the ESWT group and then 31 patients in the endoscopic plantar fascial release group, and they had their outcomes listed here. And basically, the plantar fascial release group did have better outcomes later on down the line, 2 to 3 years after completion, but it wasn't statistically significant. So these are two very comparable treatment options then, especially as a useful non-invasive treatment, reducing necessity for surgical procedures. That's what I found from this article. Next, I'll pass it to Lieutenant Miriam.
So now we're going to go ahead and look at the meta-analysis examining extracorporeal shockwave therapy versus a placebo. So we took this to mean that it was comparable to conservative treatment, because in order to be included in this meta-analysis, they had to fail at least 3 months of conservative treatment. Some of the articles required you to fail 2 pharmacological and 3 non-pharmacological treatments. Most of them you had to fail conservative treatment for 6 months. So the meta-analysis examined 7 RCTs. The primary outcome measures were changes in the visual analog scale for pain. So some of the results that they found, better composite scores versus in the ESWT, composite VAS scores at 12 weeks compared to the placebo, and that was statistically significant. There was a higher absolute reduction in pain scores versus the placebo after 12 weeks compared to the placebo, and then reduction with pain taking first steps and during ADLs were also statistically significantly higher than the placebo. However, in the methods of their meta-analysis, they defined a success rate as 60% reduction in VAS score, and their results did not reach significance. And then they also looked at the Rolls and Maudsley score, which is a nominal 4-point scale, looking at stayed the same or got worse is a 1, 2 is got slightly better, 3 is got a little bit is a good improvement, and 4 is excellent improvement. And all of there's a significant change of patients in the ESWT group moving into the good to excellent scores. So all in all, there's favorable results. 5 out of 6 outcome measures show significant difference from the placebo. There's promising long-term effects. Some of them looked up over a year. Some of the RCTs looked up results past a year, but there weren't enough to do included in the meta-analysis. But the RCTs that on their own were promising. So the inclusion criteria for this RCT or this meta-analysis rather, it had to be prospective, placebo-controlled, randomized controlled trials. The patients had to have at least 3 months or greater of history of failed conservative treatment. Exclusion criteria, I thought this was really interesting. They excluded all RCTs that included local anesthesia during the extracorporeal shockwave therapy because they wanted to keep things on a level playing field. And then they couldn't have any comorbidities, and if the study was not randomized, it was excluded as well. The limitations that they found, and we found as well, the type of the extracorporeal shockwave therapy was not controlled, so there's the radial and the focused different types of shockwaves, and they included both in the study. and the treatment dosage was not controlled. But what they found is because there's this overwhelming evidence that it still is positive regardless of the dosage, the type of shockwave, they concluded, and we concur, that perhaps the dosage is not super important in terms of effectiveness. And then they also reported a possible positive reporting bias. So all in all, with all of our different studies, we found that extracorporeal shockwave therapy is an effective, safe and effective treatment modality. If the patient fails to respond to conservative treatment, it's a viable option to improve long-term outcomes. Pain is reduced and functional abilities are improved with extracorporeal shockwave therapy quicker than conventional therapy. So if we were out in the clinic outside of the military and money wasn't an option or object, and someone had the money to pay for it, this might be a treatment option to consider if they're trying to get a quick recovery. Type and regime didn't seem to matter too much, but they do suggest that maybe medium level energy is the most efficient dosage. One of the articles we looked at had some predictors for outcomes. So for poor predictor outcomes, some of the factors that made this not maybe a great treatment option were young age, hours spent walking, if you had a pre-existing psychological disorder, and if you had diabetes. So going back through the safety, effectiveness, and costs, it's safe, but however with high doses, you can have hemorrhage and soft tissue damage through cavitations, and that's why we recommend the moderate dosage. Effectiveness, when conservative treatment fails, extracorporeal shockwave therapy is found to be effective in treating chronic plantar fasciitis. And then except for those patients with those poor outcome predictors. Cost, extracorporeal shockwave therapy is not a cheap treatment. It ranges typically from $900 to $1,500 for 3 treatments with low energy, and then with a high energy, you usually just do the one treatment, but it ranges from $1,000 to $3,000. But its advantage is the one-time treatment. So all in all, our recommendations are, if your patient is failing conservative physical therapy and other modalities for chronic plantar fasciitis, extracorporeal shockwave therapy is a viable treatment option, especially as an alternative to surgery. And we've included this ladder that was involved in one of our clinical practice guidelines, and it shows that the treatment for plantar fasciitis starts off in the initial tier, and that's before this becomes a chronic problem. So for the first 6 weeks, you look at things like padding, strapping, stretching, shoe recommendations, like a home exercise program, and maybe a corticosteroid injection. Second tier, you keep custom orthotics on the table, corticosteroid injection, also night splints, and then coming into the clinic for physical therapy. And then the third tier, after that 6 months of conservative treatment, you either opt for a extracorporeal shockwave therapy or surgery typically. And these are our citations. Do I have any questions?